Just give me a second, guys. We are starting a streaming so that you can watch it at any time. All right. All right. So let's finally start with the session. All right. I hope you are all doing good. Okay. And I hope you are all not very worried about your exams also. So these last 30 days, definitely they're going to change so many things. I want you to shut down all the social media, whatever you can do. Don't watch any statuses on WhatsApp. Let others enjoy whatever they're doing. Let them have fun. When your time come, you will also will have fun. Okay. So now let's focus on topics we're going to discuss today. So today's approach will be again same. Just look at those MCQs and try to attempt this MCQ, because in exam it's not necessary. The thing will come from whatever you have read. Okay. So you can go blank in any topic, but you have to come out as a winner, because you should have that access. Because you have already studied so much, right? You have studied so much of subjects, so you know basic things about medicine. Then how to apply that, it's up to you. Okay, so let's start with the first MCQ. All right, as it is given over here, prolactinoma versus non-functioning macroadenoma. All right, so we have a 42-year-old man, okay, has bitemporal hemianopia, 2.2 centimeter pituitary mass. That means there is a pituitary adenoma, okay, which is also compressing on the optic chiasma. Prolactin level now, it's 120 nanogram. Okay, so if prolactin level is more than 200, okay, that's your hyperprolactinemia. And if it is more than 2000, okay, and then that is mostly because of the prolactinoma. Okay, and that is prolactinoma. That means tumor of the lactotrophs of the anterior pituitary. Okay, and here it is just called as hyperprolactinemia, or the symptoms will be seen. Now in this condition, because you didn't know that 50, okay, 50 to 150 is the like a hook effect range. This is called as hook effect range. What is hook effect range? That means your prolactin in this range can most of the times you just have to reevaluate the patient. Okay, they can go either get back normal or they can worsen also. Okay, that's your hook effect. Okay, so what is the next best step now? Yes, try to answer this question. Correct. Very good. So we will repeat prolactin test after dilution. All right. So here we go. Okay. So as we can see, a prolactin of 120 nanogram is the hook effect zone. Okay. That is for large tumor. So this can be a non-functioning adenoma. So now when we talk about the prolactinoma versus non-functioning adenoma, check at the levels. Okay. So if it is more than 200, you can say it's a prolactinoma. And if it's more than 2000, then definitely there has to be adenoma. Okay. Then 20 to 150, that's your non-functioning adenoma. Now, treatment for prolactinoma is very, very important. You should remember cabergoline. That means a dopaminergic agonist. Okay. That means we are giving a drug therapy even in well-established prolactinoma. Whereas as this patient was having non-functioning adenoma, that means there were no features of galacturia, etc. Right? There were no features suggestive that the prolactin is increased. Okay, this is mostly non-functioning adenoma. So was not there, absent. So because of this, you just remember with this clue that this is non-functioning adenoma. Prolactin level will be in the mid-range or hook effect zone. And in this case, we just have to do surgery. Whereas in case of prolactinoma, which is established, we have to give cabergoline. Okay, we will discuss that with the next case now. Don't worry. Yes. So we have here the growth hormone adenoma versus non-functioning tumor with elevated IGF-1. Okay, so this is also one commonly confused topic in your exams. So I've tried to compare or give you very close DDs. Based on that, we will just diagnose. Okay, many people know that growth hormones, all the features of acromegaly, etc., frontal bossing, etc. You guys know. Just imagine the great Khali, right? You know everything about that. We study also saw growth hormone level. We can check IGF-1. We can check, which is secreted by the liver, right? Which is produced in the liver. Similarly, what to do then if patient is having non-functioning tumor with elevated IGF? What to expect? Let's see this question. So we have a 38-year-old woman with 1.7 centimeter pituitary malignancy is there. That means pituitary adenoma is there. Her IGF-1 is mildly elevated, but she has no clinical features of acromegaly. GH level is 3.5. that is growth hormone level. Okay, fasting. OGTT shows growth hormone suppression to 0.8. That means the issue can be something else, or there is a no like growth hormone is getting better. That means there is not significant adenoma over here. So what should be the treatment in this case? Yes, can you try? Yes, good, nice. Okay, yes, okay. So in this case, as growth hormone suppression, okay, this suppression glucose rules out the acromegaly. Okay, if growth hormone would have not suppressed, then you would have suspected acromegaly. So this has to be a mild IGF-1 increase that can be a physiological or lab error or due to the liver function or nutritional issues. Okay, so this is just an incidentoloma with IGF-1 rise. Okay, so you just have to wait and watch, right? So symptoms will not be much, but the treatment over here is observation. All right. And if the patient had the features of acromegaly in this case, the treatment would have been surgery first and then the medical. Okay, this is about the growth hormone. We'll come back to growth hormone again. Don't worry about this. Okay. Now, this question. A 28-year-old, just tell me what is the condition first of all. Central obesity is there. I'll just imagine a person with like this. Central obesity is there. Okay, like this. Right. With violaceous tries are there. Okay. Hypertension is also there. High cortisol, SIADH is high. Okay. And dexamethasone suppression test shows no suppression. All right. So what is the next step in this case? Exactly. This is Cushing's. All right. This is exactly the Cushing's disease or syndrome, what we can say. Cushing's syndrome. But is it because of the pituitary? What do you think? Or is this because of the adrenal cause? Yes. Yes. This is because mostly the pituitary. No. So why pituitary? I'm saying because if it is adrenal cause, your ACTH would be not normal. ACTH would be normal or low. Okay, ACTH is high. So it is mostly a ACTH dependent. Okay, it is a ACTH dependent pituitary adenoma. All right, or sorry, just Cushing's. Okay, that is your Cushing's disease also. What we say. Okay, Cushing's. Now for confirmation once, we will just see, yeah, due to ectopic ACTH or pituitary. Very good. Now for confirmation of that, okay. So now for confirmation of that, is it ectopic or Cushing's? We check the inferior petrosal sinus. Where is this inferior petrosal sinus sampling? IPSS. Where this is located? This is near pituitary. Okay, therefore, in case of Cushing's disease, okay, in case of Cushing's disease, this inferior petrosal sinus ratio, where we check the cortisol, will be high. Okay, not in case of ectopic. Okay, so let's compare now with this. So high ACTH will be in case of Cushing's. This is over here. Here also you can see high ACTH. But now when we give the dexamethasone in this cases, you will see 50%, more than 50% of suppression, whereas there is a no suppression in case of ectopic. Why? Because it is not ACTH dependent at all, right? The cortisol we are getting, it is not ACTH dependent. So there is no role of negative feedback mechanism. If it is coming from the pituitary and you are just suppressing it, then negative feedback mechanism might help. That means you are giving dexamethasone suppression and causing negative feedback. That will help if it is coming from pituitary. Okay, that's why if it is coming from ectopic source, there will be no suppression on the dexamethasone suppression test. All right. Also, remember this petrosal sinus gradient will be central to peripheral gradient will be there. Okay, here there is no gradient. And MRI pituitary will also show microadenoma. And next test, therefore, in this case is IPSS, that is inferior petrosal sinus sampling. Okay, right. Now, coming to next question. This is a very, very good, important question. A 50-year-old man presents with sudden headache, vomiting, ophthalmoplegia is there, and MRI showing hemorrhage into the pituitary. Okay, hemorrhage into pituitary mass. So visual loss is also present. What is the next best step? First, can you tell me what is this diagnosis? We have yesterday also discussed this thing. Very nice. This is pituitary apoplexy. Very good. Okay, first of all, you can just imagine this is acute condition. Okay. Also, there is no history of pregnancy or, there is no pituitary infarction because of PPH, etc. So Sheehan syndrome is obviously not the case. So now, how do we treat this pituitary apoplexy? That's very, very important. So For majority of the pituitary condition, you can give steroids. Okay, so the answer over here is yes. What do you think? What is the answer? A is the correct answer. Okay, so high dose steroids and the urgent decompression would be recommended in this case. Okay, because there is a symptoms of the increase in intracranial tension. All right, so decompression is needed, but with the high dose steroids because this is the apoplexy. Now, if you had not known this pituitary apoplexy, you would have said that cabergoline because suspecting the macroadenoma. In exams, they can confuse you with a macroadenoma, okay, with this type of pituitary apoplexy. Okay, so make sure while solving those questions, you're keeping these things in mind. Just a second, guys. Somebody is calling me. Yeah, sorry. Okay, so as we said, yesterday also we discussed this. Apoplexy will be acute headache, vision loss, hemorrhage in cellular mass will be there, and IV steroids plus surgery is the treatment of the choice in these cases. All right, now let's see one more question. A 45-year-old male underwent transsphenoidal surgery for 3 centimeter non-functioning pituitary macroadenoma. Okay, and it is also invading the cavernous sinus. Now, this is very, very important, guys. This MCQ will come in your exams. So, as you can see, looking at the options, we might think that this is related to the growth hormone. Okay, so let's see first question. So, underwent already surgery has been done, and still after that, you can see the macroadenoma is invading the cavernous sinus. Okay, post-operative MRI is showing residual tumor. So, this is the case of residual tumor of the pituitary even after transsphenoidal resection. After transsphenoidal resection. Okay, so this indication is not for medical also. Okay, so what do you think is the treatment in this case? Yes, exactly, radiotherapy. Okay, radiotherapy is the treatment in this case. Okay, fractionated or stereotactic radiotherapy is the treatment of the choice. Let's see this topic. So, non-functioning tumors don't respond to dopaminergic agonist or SRLs, that is octreotide, etc. Okay, any drugs like somatostatin receptors, octreotide, or even this is the answer over here. Okay, even dopamine agonist, they will not respond. So the answer over here is radiotherapy. Observation, why would we do observation, right? It is invading the cavernous sinus, and there are so many nerves around that, right? So definitely we have to intervene with something. Okay, so surgery is first line in these cases, non-functioning tumors, what we say. Then if they're not helping, give dopaminergic agonist. So obviously this is not helpful in this case. Sorry. If we talk about the non-functioning dopaminergic agonist, octreotide is not helpful. Okay. Only surgery or radiotherapy. So if this is not helping, come to this. Right. And if they're functional tumor, then first surgery, then dopaminergic agonist. Okay. This is typically in case of growth hormone related tumors or acromegaly. Okay. Acromegaly, basically. So first step is always surgery, except in case of prolactinoma. Okay, in prolactinoma, you can give a dopaminergic agonist as a first line. And then if it's not helping, then we go for surgery. Okay, so let's see next question now. Yeah, this is again the question, post-surgery acromegaly management. So 38-year-old woman is there with acromegaly, undergoes further growth hormone secreting macroadenoma, surgery for the growth hormone secreting macroadenoma. IGF-1 remains elevated post-operatively. MRI shows small residual tumor near the optic chiasma. What is the next best step now? Okay, see, is this functional? Yeah. Okay. So what do we do now? Yes. So again, remember one thing. Here. If it is close, okay, if it is close to nerves, okay, this is also one more indication for the radio surgery. Okay. If the adenoma, it's functional. Okay, adenoma, even if it is functional and it is close to nerves, if it is close to nerves, then also we should do stereotactic radiosurgery. Okay, if residual tumor is close to optic nerve, radiosurgery is avoided, is initially, and the first line treatment will be your SRLs or octreotide. Okay, so I did it wrong over here. Sorry. Okay, So if it is close to nerve, then we avoid radiosurgery. We don't do radiosurgery, but we give the medication treatment. Okay. SRLs we give, right? Because obviously radiosurgery, if you do, nerves can get damaged in these cases. All right. So pegvisomens is a reserved SRL if everything is failing. All right. So as we saw, repeat surgery, high risk, low yield in this case. Radiosurgery, avoid near optic nerves, and SRLs are indicated like octreotide, and pegvisomant is used as a backup only. So here we learned two things. First is whenever it's close to nerve, go for the medical therapy only, or you can give particularly octreotide, and if it doesn't help, then pegvisomant. Okay, that's how we go ahead, right? Yeah. Now next question. 26-year-old woman presents with amenorrhea, galactorrhea, bitemporal hemianopia. Okay, again here you can see, yes, correct. Okay, this is your pituitary microadenoma. Also, you can see optic chiasma compression, prolactin level is 2200. So what is the best initial treatment? Many of you are saying A, many of you are saying B. So as I already mentioned, in prolactinomas, we mostly do dopaminergic agonist therapy. So B is the correct answer. Okay, cabergoline, not transfenodal resection. Okay. So despite optic chiasma compression, prolactin level more than 200 suggests prolactinoma. Okay, which shrinks rapidly with this dopaminergic agonist. So surgery can be used second line only if patient is having dopaminergic agonist resistance or apoplexy is there. Okay, so yes, I know I'm going little faster over here, but make sure these points are very, very important for your exams. Okay, they are definitely going to test you in these aspects. Okay, I'm covering in detail only. Yeah. But you must have read in a different aspect till now, right? The disease and everything, investigation and then treatment and all. This is not required. Now, in this last 30 days, you should be able to revise like this. Okay, revise like this pro. That means comparing 2-3 things at one time. So that will only help you to, rule out the options in the exams. Okay, so here we just learned the simple topic over here. Whenever patient is having macroadenoma of the pituitary, we usually go for the dopaminergic agonist therapy. Then we do the transferodal resection. Okay, so if prolactinoma is there, then definitely surgery will be the second line. All right. And in case of non-functioning, surgery will be the first line. Okay. Yes. Now, one more question of the pituitary. A patient with residual pituitary microadenoma underwent fractionated radiotherapy 4 years ago. Okay, there was a residual tumor. Radiotherapy is already done. He now presents with fatigue, hyponatremia, hypotension. Which hormone is most likely deficient? Very easy question. Very easy topic. Yeah, B is the right answer, ACTH, right? Because cortisol is the deficient in this case. So probably ACTH would be the problem. So with this, we will discuss now what are the other things that are associated with this. Okay, let's see now. So obviously here hypopituitarism is there and ACTH deficiency causing all these symptoms of the deficiency. Now let's answer this. Already the answer is given over here. Yeah, 34-year-old woman who this is the hypertension, centripetal obesity is there, diabetes is there. All right. So there is a cortisol excess. Now ACTH is suppressed in this case. We have already seen this case. Cortisol is high and MRI is normal. That means this has to be adrenal adenoma. No doubt about that, right? So this has to be adrenal adenoma because the ACTH is suppressed. If ACTH was high, then it was because of the pituitary cause. Okay, pituitary cause. All right. Okay. Yes. So guys, is this helping you all, or like, do you think that with this discussion we are able to, upskill your game of solving questions, particularly when we talk about the medicine? Is this really helping, or we should do extra some things? What do you say? Okay. Because see, I would tell you one thing. I've also done recorded sessions and all. When you compare these sessions with the recorded sessions, okay, you might find that this session are not that good, or maybe some things like that. And there is a tendency to compare with the other teachers also when you compare. But make sure this is a live session, right? So when we talk about the live session, game absolutely changes. When we have a recorded session, we have n number of the sources in front of us. Yes, live sessions are much better. I agree with that. But live sessions maybe not that far some of the times as you expect. All right. Okay. Wonderful, wonderful. In question bank also, I will tell you, if you are not able to solve some basic questions, that's okay. I'm telling you because in Neetpg examination, they are gonna check your core topics or core concepts. And what we are discussing are the core concepts. Okay, they are not gonna ask you about the size and centimeter in your Neetpg examination. So even if first 4 or 5 questions in your question bank, you make a mistake, that's okay, because that's a factual information. And like how many times you must have revised till you won't remember that stuff. And those questions will be 10 to 15 questions in a whole paper. Okay, but most of the questions, considering recent pattern, as I yesterday also said, NEET UG, NEET super specialty, paper is going to be difficult. Okay, so for that, these core concepts will only help. Okay, you might, obviously, that might also help you to rule out some options. I'm not saying that you should not revise that completely. Just trust your notes, revise whatever you did till now. And if you have time or if you have any sources, try to, solve questions like this now, which will help you to gain some confidence and will give you extra edge over the questions of the topics which you even don't know. Okay. Yes. So now let's start with this. So here we have already discussed pituitary adenoma, adrenal adenoma, right? In pituitary adenoma, SIADH will be high. Here it will be adrenal adenoma, it will be low. And in case of ectopic SIADH also, it will be high. Now, after this, we did dexamethasone suppression test, right? So dexamethasone suppression test, when we do this, okay, cortisol will also be high in all of this. When we do dexamethasone suppression test, there will be suppression only in case of pituitary adenoma because of the negative feedback. But rest of the times, you will not see dexamethasone suppression test. Now, how do we rule out CT or adrenal adenoma and ectopic SIADH? Or even if you get confused between pituitary and ectopic SIADH, that is with the help of IPSS. Also with the help of imaging. Okay, IPSS, as I explained already, inferior petrosal sinus sampling. Okay, yes. And for adrenal, we can any day do the CT adrenals. Okay, now coming to one very, very important question. And this is definitely will be asked in your exam. Okay, this is definitely one MCQ. If you ask me that will it be asked in my exam, so that is this one MCQ. Okay, a 31-year-old woman presents with weight gain, facial rounding, hypertension, easy bruising. Features of Cushing's are there, no doubt about that. They have also given 24-hour urinary free cortisol is high. Overnight 1 mg dexamethasone suppression test, morning cortisol is 11 microgram per deciliter. No suppression is there. Okay, so probably the cause would be adrenals or ectopic. Plasma SIADH is elevated in this case though. Okay, so what is the next best step now to just rule out the condition in this case? Okay, so they have done dexamethasone suppression test already. That's the overnight 1 mg dexamethasone suppression. Huh? That's not like high dose dexa suppression. High dose dexa suppression, we give 6 mg of dexamethasone, and with the help of high dose dexa only, we can get the idea of the pituitary axis. Okay, so now with this knowledge, let me know your answer. Exactly. Okay. Yes, now you are right. All right. So we will still do high dose DEXA suppression test in this case. Okay. Why I will tell you now. So the first stage is always in case of Cushing's, whenever you have the patient of Cushing's, first test is to confirm the hypercortisolism. So in your patient, hypercortisolism is definitely there. They've already given that it is more than 3 times the upper normal limit. Now, second step is to check the ACTH. Okay, ACTH is, if ACTH is low, that's adrenal cause. If it is high or normal, then it's a dependent. ACTH dependent. So ACTH can also be ectopic ACTH or the pituitary related ACTH. Now, in case of pituitary related ACTH only, you will see the high dose dexamethasone suppression test. Okay. So then we localize ACTH source. Okay, with the help of high dose DEXA suppression test. If it is pituitary adenoma, there will be suppression. If it is ectopic, there will be no suppression. Now, you might ask me that why I added 1 mg dexamethasone over here then. Okay, why this overnight 1 mg DEXA suppression test was added? Well, this was something to fool you around. Okay, this will make you confused. Okay, you have to be very precise in what you are learning. Overnight 1 mg dexamethasone suppression test is actually included in the first step of the screening only in Harrison. Okay, so that's not relevant for us. Just remember, if you are confused between adrenal or ectopic or pituitary, for that we have to do this dexamethasone, which is high dose dexamethasone suppression test. Also one more clue is there for us: SIADH stimulation test. Okay, yeah. So CRS stimulation test will be positive if the pituitary cause is there. Okay, that means you are giving corticotropin releasing hormone that comes from the hypothalamus, and obviously pituitary will show the effects of that. Okay, so pituitary, it will be increased response, but no response in ectopic and or blunted response. All right, and obviously when we do the inferior petrosal sinus sampling, that will help you. That's a gold standard for differentiating ectopic versus pituitary ACTH. Okay, so I hope you are able to understand this point. Okay, right? So high dose DEXA suppression test, that is 8 mg overnight or 2 mg 6 early into 2 days, helps differentiate pituitary versus ectopic ACTH. Okay, right. Now coming to this one more question of the Cushing syndrome only. A patient with persistent Cushing's disease after transpyramidal resection found to have unresectable macroadenoma. Which medical therapy targets cortisol receptors rather than cortisol synthesis? So we are talking about the treatment of the Cushing syndrome now. Okay, you know surgery is the first line, but apart from that, which is the drug that particularly act on the cortisol receptors? Okay, cortisol receptor is a different thing. Cortisol synthesis is a different thing. That's okay. Even if you don't know, I will tell you the mechanism of each of this. Answer over here is mifepristone. Okay. Yeah. So here is the mechanisms of each of this, right? So first of all, obviously, first line is transpyramidal resection. If pituitary cause is there, obviously, okay, post-op hypocortisolism can be seen. Therefore, steroids have to be given. Okay, so here the key is the transpyramidal resection is the first line of surgery. Even 5 to 10% can show recurrence. That's okay for us. No, they are not going to ask about this. Okay, repeat surgery, yes, that can be asked if like first surgery fails. Okay, so if first surgery fails, and patient is having, there is a strong indicator that pituitary source is only there, then you can do repeat surgery. Then coming to this medical therapies, so in which ketoconazole, if they ask about the mechanism, it blocks multiple P450 enzymes. Thereby, synthesis of the steroid is inhibited with this. Okay. Then also we have osilodrostat. It is a new drug basically that also inhibits the steroid synthesis with the inhibition of the 11 beta hydroxylase. Okay, so as we can see, blocks 11 beta hydroxylase. Very important. The metarapone is also one which blocks the 11 beta hydroxylase. So obviously the side effects. So if you remember that axis, I'm not added that axis of the hormone synthesis or steroidogenesis there. If suppose this is your starting point, okay, so this is the one point, and here we have 2 points over like this. Okay, so 11 beta hydroxylase almost forms the age or important phase of 3 of them or 2 of them over here. Okay, for 2 of these, very, very important. Okay, this is 11 beta hydroxylase. So this is very important for this 2 of this. And these 2, that means with the help of this, your cortisol and mineralocorticoids. Okay, mineralocorticoids. And here you have the 6 steroids. Okay, so what will happen if 11 beta hydroxylase is inhibited? Your sex steroids will grow. Okay, this pathway will shift towards this. Therefore, you will have the higher amount of the androgen, higher amount of the sex steroids in these cases. And that's why you will see the features of androgenism like hirsutism, etc. on these cases. Okay, all right. And finally, mitotain is adrenolytic. Okay, that's an important mechanism. Now, glucocorticoid receptor antagonist. That was the question, right? That was the MCQ. Cortisol receptors will be acted by particularly your mifepristone. Okay, so mifepristone acts on that. It's indicated for hyperglycemia, and it controls in Cushing basically, and it can block the action of the cortisol peripherally. Okay, so blocks the cortisol action peripherally. Apart from that, we have pasireotide. These are your somatostatin receptor ligands. Okay, they have affinity with SST5. This is the receptor, and they lower the ACTH in some patients. So it's under study only. Then cabergoline can also be given in this case, which can add as a synergy to the other treatment, not a permanent treatment. Finally, for ADH or like adrenal adenoma, you can do adenectomy also. But obviously, after that, there is a risk of Nelson syndrome. So what is that Nelson syndrome? Nelson syndrome is pituitary adenoma expansion with high SIADH and hyperpigmentation. Okay, that means your adrenal is gone now. Now the body will send positive feedback mechanism that I don't have any hormone. Please secrete more and more SIADH. So because of that more and more high SIADH, your hyperpigmentation will occur. Okay, that is called as Nelson syndrome, which is typical for the adrenalectomy patients, right? And finally, if everything helps, radiotherapy can be done. Okay, now coming to the very important point over here about the SIADH, psychogenic polydipsia, all right, nephrogenic diabetes insipidus, and all this is very important for your exams. Let's see now. As we know, anterior pituitary hormone we have discussed till now. Okay, now let's discuss posterior pituitary. Two only, your ADH and oxytocin. Oxytocin is okay, you must have studied that in the OBGYN, so I'm not explaining that. But here, ADH is very important. Vasopressin ADH is important for us. Okay, so main hormone AVP and oxytocin. Okay, major clinical disease, you know, AVP deficiency is diabetes insipidus, and SIADH is the AVP excess, arginine vasopressin excess. It can be SIADH can be produced from the brain, also from the malignant tissues or any other different tissues. So you can see it in the paraneoplastic manifestation also. Very important. Okay, whereas diabetes insipidus is mainly an issue of two things, either pituitary or either kidney. If it is because of the pituitary, we call central diabetes insipidus. If it is because of the kidneys or if the receptor problem is there, that is called as nephrogenic diabetes insipidus. I hope you are all aware about this time. Okay. Now let's see MCQ on this. You already know majority of the stuff with this. Yes. So this is a question. Again, this can be asked in your exams. Okay. Very important topic. Right. So 29-year-old woman is there. Known case of bipolar disorder. So bipolar disorder, that means she must be taking lithium. But here students do mistake. They don't read whole question. Let's see now. Presents with excessive thirst and polyuria for 6 months. That means there is a ADH excess for sure. Okay. ADH is in excess for sure. We'll just have to look out that it is because of the central ADH or is it because of the nephrogenic diabetes. Let's see that now. She also 8 liters of water daily. That's huge. So can be a psychogenic polydipsia also. No history of trauma. Lithium use is not there. Okay, no history. Right? Bipolar is not only treated with lithium. There are other antipsychotics also which can be given in the bipolar disorder. So right now she is not on the lithium. That rules out nephrogenic diabetes insipidus. Visual symptoms are also not there. So central diabetes insipidus might also be a questionable thing over here. Now let's see what are the labs in this case. Okay, so central is not there. Nephrogenic is not there. Then what it can? So vitals are normal. Physical exams like euvolemia, no edema. Okay, euvolemia is there. Labs shows serum sodium 140, osmolarity is 285, and urine osmolarity is 1110. That means low urine osmolarity is there and high serum osmolarity is there. Okay, then urine output is 5.8 liter per day. So when we do the water deprivation test now in these cases, that means we are not giving any water to the person, and after that we are checking urine osmolarity of the person. So if you check this, urine osmolarity increases when the water deprivation test is done. And whenever you see this scenario with your eyes closed, you can click every time. The answer is yes. C is the correct answer. Very nice, all of you. Okay, C is the correct answer. Primary psychogenic polydipsia. Okay, so water deprivation test. Whenever you see benefit with that, there will be primary psychogenic polydipsia. Okay, right now. So that's what we just saw right now. Okay, primary diabetes insipidus, nephrogenic diabetes insipidus, and the primary polydipsia. Okay, so AVP will be inappropriately low in case of pituitary. Here, in case of nephrogenic, it is high usually AVP, arginine vasopressin, and here primary polydipsia, it is mostly normal to high. Okay, high. Why it is high? Because your urine is going very dilute. Okay, so that's the function, right? Okay. Okay, urine is going very dilute, so antidiuretic hormone will get produced to make concentrated urine. That's why you can see even in psychogenic polydipsia or primary polydipsia, you have the high ADH. Okay, so in case of nephrogenic, it's because of the negative or positive feedback. Okay, then urine osmolarity, as we check, it will be weak or no rise in all the conditions. Okay, here it can rise partially, but typically it is submaximal again. Okay, not very high. Urine osmolarity is low in all these cases. Then response to desmopressin, it will be marked or very high, good response in case of obviously central diabetes insipidus because vasopressin was not there. So it is good response in this case. Okay, and in nephrogenic diabetes insipidus, no significant change, and there is the risk of water intoxication in case of primary polydipsia. Okay, yes. And posterior pituitary, obviously there will be no bright spot in case of pituitary diabetes insipidus. So in exams, please remember that never overthink about the options. Okay, just look for the clues. Don't think that you want to your approach should not be to make question correct. Your approach should be to solve the question. That's very important. Two different things. Okay, when you approach to make question correct, it's very high tendency. You just see two, three things and just click the answer, and most of the time that comes wrong. And you will feel again that how can this be wrong? I have thought so much about this, but that happens. But your approach should be to solve the case. If you solve the case, that if you solve over here, there are so many clues with that, and we come to clear-cut diagnosis. And your exam will be also same way. Okay, you will definitely get one more question in this aspect. Okay, right. So coming to this again, for treatment, pituitary diabetes insipidus, desmopressin or vasopressin has to be given. TDAVP we give by the nasal route. Okay, it comes as a nasal spray. Then primary polydipsia, you have to give the water restriction, ask the patient to water restriction, and psychiatry management. Nephrogenic diabetes insipidus, here you can give particularly thiazide diuretic. Okay, thiazide diuretic, you'll say that even thiazide diuretics is also diuretic, and already patient is excreting a lot of urine. But thiazide is particularly something which will excrete both salt and water. Okay, so because of that, urine osmolarity doesn't change or like increases better. Okay, like free loss of water will not happen if you give thiazide. If you give thiazide, sodium will also get excreted, and because of that, your volume or contraction that will not occur properly. Okay, because of dehydration and free water loss. Okay, yes, right. So even amyloid can be given, indomethacin, low sodium. That is also recommended in this case. Okay, that's all about the primary for pituitary diabetes insipidus or central diabetes insipidus, nephrogenic diabetes insipidus, and the your primary polydipsia. Now, this is something that are given. Now, one more case is about the SIADH. You know what will happen in the SIADH. The SIADH, in case of SIADH, the ADH will be in excess, right? Antidiuretic hormone will be in excess. Most of the times you have the euvolemia in these cases. Okay, euvolemia. And patient presents with the hyponatremia. Okay. Most of the time, patient will have euvolemia, hyponatremia. We'll discuss that when we discuss the electrolyte session. So apart from this, I'm gonna take you I'm gonna take few important sessions, like ECG session we will take. There we will just discuss ECG that day. Complete ECG we'll discuss. Similarly, electrolytes and fluids session. Okay, electrolytes, fluids, and ABG session we will take one. Okay. Even one session on the X-rays and CTs. Important X-rays and CTs. Okay, so that any question comes in this, you should be able to solve. At least expect a two to three question on the ECG, two question on the fluids, ABG, all this entire topic, and X-ray series at least 3 to 4 questions. Okay, so medicine is all about the evidences, and this will definitely come in your exams. Okay, yeah. So as we were discussing SIADH, we'll have euvolemia, hyponatremia. Okay. Yes. So there are like, if they ask like one of the, there's one tricky question about the SIADH. I hope I've added it over here. Yeah, this is the question. Try to solve this question, please. It is slightly difficult. It is slightly difficult. Let's see if you can solve this or not. A patient with chronic euvolemic hyponatremia is there. So SIADH will mostly a chronic case. Okay, inappropriately concentrated urine will be there. Okay, because ADH is in the excess. Okay, ADH is in excess. That means concentrated urine will be there. And suspect to have SIADH. If genetic testing reveals an activating mutation of the V2 receptor, okay, which specific subtype might this represent? Very, very easy question. It's framed like that. I have framed it like that so that it becomes a little easier for you. But in exam, you will bang your head 10 times. Like, how come we didn't know that? Just like central diabetes insipidus, we already know. Just like central diabetes insipidus, because of the ADH deficiency, we have nephrogenic diabetes insipidus, right? We already know that stuff. But how didn't we know? We didn't know about the SIADH. That central SIADH is also there, and one peripheral SIADH is also there, where there is a mutation of the V2 receptor in the kidneys. Okay. So this is your NSAID, that is also called as nephrogenic syndrome of inappropriate antidiuresis. So for this topic only, I've added this question. So it's very rare though. This is only seen in 5% of people, but this is very rare. Okay, but this can be a tricky thing if they can ask in exams. Baki SIDH ka question you will easily solve. I'm 100% sure for that. The treatment is fluid restriction, etc. You already know about that. Don't get much panic. Okay, whenever you heard of water deprivation test was done, SIDH should go out of your mind. Okay, whenever you hear the water deprivation test was done, that means psychogenic polydipsia was the cause, or they will tell you based on that if it is helping after water deprivation, then psychogenic polydipsia. If it's not helping, then either central or nephrogenic diabetes insipidus. And obviously, if there is a drug history, then nephrogenic. If there is no drug history, then central. Okay, so this is just a simple thing that is written about over here about SIDH. So hypervolemic hyponatremia, if there is, then we give hypertonic saline in case of SIDH. If hypovolemic is there, remember, if hypervolemic, then hypertonic saline might help. But if it is hypovolemic, then mostly fluid restriction will help. Okay. Okay, sorry. If this is hypovolemic, then you have to give fluids, but they should be isotonic or hypertonic fluids. Okay. Isotonic hypertonic fluids. If patient's already fluid status is low, that means because of the hypovolemia, patient is having hyponatremia. But most of the time, if it is SIDH or euvolemic, then fluid restriction will help. And even in severe cases, Vaptans will help. Okay, 3% saline and Vaptans will help. Now, many students will get confused that patient typically they will give history of SIDH and the patient's hemodynamic status or patient's mental status is not very good. Patient is confused and sodium is just 114. So what should we do in this case? So in this case, that's why I have added 3% saline should be given. Okay, or hypertonic saline is your treatment of first choice and Vaptans. Okay. Then after that, you can do the fluid restriction. Okay. So even if it's SIDH and patient is having acute symptoms of confusion, etc., then treatment is severe. Then treatment is hypertonic saline. I hope there is no confusion about this. Okay. But remember, during this, watch for overcorrection of the sodium. So normally we have 6 to 8 milli equivalent of sodium per 24 hours. Okay. So if the change in the sodium per day is more than that, then you guys already very well know osmotic demyelination occurs. Okay, so because of this osmotic demyelination, patient might develop quadriplegia. Okay, also called as central pontine malinosis, right? CPM. Okay, and if V2 receptor is mutated, then osmotic diuretic might help, like for example, urea. Okay, so it's very rare that they can ask you, but these things are important, right? Right. Now, what is the most common cause? So now we will quickly discuss hypothyroidism. Okay, we'll quickly discuss hypothyroidism and then we'll end the session because already 1 hour. Okay, let's to pass. Right. So quickly, let's see hypothyroidism now, which is the most common cause that underlies the permanent neonatal hypothyroidism. Right? Anybody? Permanent neonatal hypothyroidism in the iodine sufficient areas. Yes, anybody? Already the answer is written over here. Don't see that. Thyroid dysgenesis is the correct answer. Okay, thyroid dysgenesis. Thyroid gland dysgenesis is the correct answer. See, all these detailed notes. Okay, if you want, I can send that in our discussion group, but they are now little over in detail. If you want the transcript of whatever I'm teaching, I will share that in the group. Okay, also in the channel, I will share this so that you can just go through whatever topics we have covered, right? And I will remove those annotations so that you will feel little fresh while, or if you want, we can share it with the annotation also, no problem. Okay, so when we're talking about the hypothyroidism, congenitally, thyroid dysgenesis is the 65% most common cause. After that, dysharmonogenesis is the cause. Now, I will not take you a lot of time in hypothyroidism. They will ask you about the subclinical hypothyroidism. They are fond of this, or they might ask you about they will not ask about the Hashimoto's also. Either they will ask about the subclinical hypothyroidism, when to treat, or they can ask you about the complications of the hypothyroidism, myxedema, coma, etc. Now let's see this. Which finding best indicates the autoimmune rather than other causes of the hypothyroidism. It's very easy. Right, you guys know elevated TSH receptor blocking immunoglobulins, TSH receptor blocking antibodies. Okay, that would be your answer for this. Obviously, antibodies are positive, that means autoimmune mechanism will be there. Now, this is about the system now, symptoms now, about the hypothyroidism. You know, thyroid hormone is for the metabolism. Now, whenever there is a low thyroid hormone, obviously, entire metabolism will go down, but there are some specific questions about this. That's why I added this MCQ. So, what is the most specific hypothyroidism feature in the commonly listed symptoms below? So, weight gain, bradycardia, delayed tendon relaxation, or hair loss. So, the answer is 3. Very good. Delayed tendon reflex relaxation is the correct answer. Okay. This is just a factual question. Don't worry about this. Now, this sign, anybody knows what this sign called as? This is called as Boltzmann sign. Okay, anybody? It's okay. Boltzmann sign. Then they're not going to ask this, but it's okay. Okay. Yeah. 45-year-old patient. Next, let's see now what is the screening or how do we screen the thyroid cases. So 45-year-old mild hypothyroid symptoms are there. Which is the single best test recommended first to screen in patients of primary hypothyroidism? It's very easy question though. Anybody? Do we check? What should we check? Yeah. Yes. Anybody? Yeah, TSH is the correct answer. Very, very easy, right? TSH is the correct answer. We never check antithyroid globulin antibodies first. Always remember, thyroid patient always check for the TSH. Okay. Yes. So now let's start with the subclinical hypothyroidism. So 32-year-old woman is there coming for routine evaluation. TSH is 6.8. Okay. So we should target normally less than 5. Here it is 5 to 10, in between 5 to 10. Free T4 is normal. Okay. Anti-TPO antibodies are positive. Okay. Anti-TPO antibodies are positive. That means Hashimoto's can be a possibility. She is planning pregnancy also in 3 months. What is the most appropriate next step in this case? What do you think? Anybody? Should we wait and recheck after 6 months? Should we start levothyroxine? Should we just confirm first, or should we start levothyroxine? Okay. Why? Why should we start it? Very, very nice. All of you, very good. I impress you. So yes, this is the case of subclinical hypothyroidism. And in case of subclinical hypothyroidism, either if patient has anti-TPO antibodies positive, or if patient has symptoms, okay, then in this case, we should start the levothyroxine. Okay, so that's the correct answer. Right? TSH mildly increased, that is 4.5 to 10. That is subclinical hypothyroidism. Free T4 will be definitely normal in this case. Okay. And symptoms often absent. Okay. Or can be fatigue or cold intolerance can be there. So when do we treat subclinical hypothyroidism? If TSH is 10, definitely we have to treat. Okay. If TSH is 10, then definitely treat. If TSH is 4.5 to 10, or symptoms of hypothyroidism is there, consider treatment. If anti-TPO antibodies, which was in our case, was a positive, pregnancy, yes, we have to treat. TSH should be less than 2.5. Okay, we have to target less than 2.5 of TSH in pregnancy. Okay, then goiter if present, consider treatment. Age less than 65 or cardiovascular risk, then consider treatment. And elderly more than 70 and symptomatic and asymptomatic, TSH is less than 10. Observe and recheck after 6 to 12 months. Okay, so not if patient is asymptomatic, TSH is also less than 10, and patient is elderly, not necessary to start treatment in this case. Okay, right. So in a nutshell, TSH more than 10, if between 4.5 to 10, symptoms should be there, and pregnant or planning to conception, and the goiters or cardiovascular risk factors present. Okay, right. So last topic now about the hypothyroid, that is inflammatory thyroiditis. So we'll quickly discuss this now. Yes, 35-year-old woman presents with painful anterior neck swelling and the fever. ESR is 85. That means thyroid inflammation is there. Okay. So whenever ESR is given, think it as an inflammation is occurring somewhere. TSH is suppressed. T3, T4, if they check, is elevated, and anti-TPO is negative. So classically thyroiditis is there. So what do we do? Obviously the answer is given over here, but what is the diagnosis? Anybody? Can they tell the diagnosis? Yes, thyroiditis. Okay. Yes. Subacute or curvane thyroiditis. Okay, this is subacute or decurvane thyroiditis, not Hashimoto's. Okay, in Hashimoto's, NDTP will be positive. The history will be given like that. Okay, here typically patient is having pain. That's very, very important. And in subacute decurvane thyroiditis, you will have the pain. Okay, and in case of infectious also, you can have the pain. Apart from this, your inflammation will be positive in decurvane thyroiditis or subacute thyroiditis. Coming to the Hashimoto's, see, your TSH will be chronically high and ESR-CRP will be normal for the Hashimoto's. So make sure you don't do this mistake. And finally, coming to the radial thyroiditis. So in radial thyroiditis, you will typically have that history of the fixed gland and fibrosis. Okay, so this history will be very typical in case of the radial thyroiditis. So radials for a rock hard. Remember this. Okay, and subacute is usually after the viral upper respiratory tract infections. Okay, so that's it for this discussion, guys. Now let's meet tomorrow. We'll try to complete thyroiditis and we'll try to start with the diabetes, and mostly we will end endocrine tomorrow. Okay, I hope you enjoyed the session. Try to be more attentive. Already you are. I'm not saying that many of you are attending questions, but I will just give you idea next time. Let's come read. Let's, you can revise some things and then we can discuss those topics as well. Okay, so tomorrow we'll discuss rest of the thyroids, read diabetes, read parathyroid and bone and mineral metabolism. Okay, yes. Okay, yes. And I hope you are solving mock test. It's my sincere request to all of you. Please solve the mock test. Okay. Yeah, PDF I will provide. No worries. Okay. Please solve the mock test as much as you can every alternate day, or maybe 3 days or maybe 2 days in a week. You should solve mock test. Okay. Yes. Thank you, guys. I will update on my YouTube channel. You can check our YouTube channel. The PDF link and the lecture recording will be updated in our Dr. Vishal Kabale is our YouTube channel. Okay, that's with my name. Okay, you can search at L which. Okay, so I will attach the PDF link on the YouTube. You can just download from there. All right, thank you so much, guys. Sleep well, revise, and have a good 8 hours sleep these days, because when you're sleeping well, the mental health really stays good. Okay, so just take care of that fact. Okay, thank you, guys. Bye bye. Okay, bye bye. If you have any doubts and all, you can just we can take a session whenever you want. We can discuss all the doubts and all. Okay, yes, bye.